You're watching Minimising Diagnostic Error, Strategies to Support Your Registrar, produced by GP Supervision Australia and presented by Dr. Simon Morgan. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
This is a topic of great interest of mine and something that I've read about and presented on over the years as a medical educator, and certainly in my role as a supervisor and a trainer of registrars. I put that quote very deliberately, I'm worried I'm going to miss something, because that is very much what often drives our registrars to maybe embrace a number of maladaptive strategies of over-testing and certainly becoming anxious about their practice. So this I endeavour to make very practical, and we'll be covering a range of approaches that you guys can use as early as tomorrow to support your registrars in this endeavour. My name's Simon Morgan. I am joining you from Awabakal country, that is based here in Newcastle, and I am a GP. I'm a medical educator with the RSCGP and with GPSA, of course. And I very, very proudly work for the local Aboriginal Medical Service here at Awabakal. So what are we covering? We're talking about factors that contribute to diagnostic error. We're talking about the integral relationship between clinical reasoning and diagnostic error. And when I think of these aspects of practice, I often really consider them as this grouping of clinical reasoning, the outcome of poor reasoning often relates to error, and another sort of element of that is uncertainty. So I guess as an encouragement as supervisors, think of this sort of trifecta of so-called soft skills, these broad aspects of practice, as sort of one of the same. Good reasoning, good management of uncertainty leads to a reduction in possible error. And as I said, and as I always endeavour to do with these workshops, very much what you can take away by way of supporting your registrars and other learners. So really, in a sense, you're here to hear this, but this is a kind of structure or a way that you might actually deliver something to a registrar if it's a more formal teaching session. I also like, and as an educator and as a participant to sessions, it's good to know what you're not going to cover. And we're not going to be covering an approach to management of an error once it's occurred in practice. These are very, very powerful teaching opportunities, and I'd absolutely encourage the occurrence of an error by one of the established doctors in the practice or by a registrar as an opportunity to learn. This is something we won't be talking about, but I just wanted to point you to one of the MDO fact sheets around sort of an approach to doing that. And of course, you know, error, near misses, is often very heavily laden with a sense of guilt or embarrassment or awkwardness. And one of the key messages, I guess, is that whole notion of open discussions around this and how we can and should use this to support each other. And we'll start with a case, because this is absolutely where registrars will be based, where we as GPs practice, and I think it'll help ground some of these issues. So let's start with a 64-year-old man. He's got, a relatively complicated past medical history with asthma, diabetes, hypertension, hypothyroidism, and atrial fibrillation. He takes some reasonably kind of complex medications. And importantly, he's a non-smoker and doesn't drink much in the way of alcohol. Now, an invitation to you at this point, if you have a pen and paper, or even just in your head, what I would really like you to do as you observe and listen to this case is to think of some of the factors that may have contributed, and obviously this is going to be a case of delayed diagnosis, which may have contributed to the delay, to the diagnostic error as such, but also maybe some of the things that you observe that might have mitigated further delay, or actually might have been a good element. This is a real case. The patient isn't this patient. This is a photo off the internet, but this patient has given me permission to talk about him. And I guess in a sense, what I'm doing here is role modelling. This isn't anything like exemplary practice, but I think that's the point when we talk to registrars about these sorts of things. And this actually happened quite a long time ago now, but it's still, I think, a very, very illustrative case. So This 64-year-old man presents with a cough a few weeks after an ERDI. At the time, certainly there was nothing especially memorable about it. Felt like he needed to clear his throat. His examination was essentially normal. And the encounters that I'm going to describe were myself as the GP, but also a few of them were managed by other doctors in the practice. And I'm sorry, it's not apparent which were which. He managed expectantly. A couple of weeks later, he's actually seen for another reason, which I didn't elaborate here, and it's documented his cough has settled. 6 weeks later, he represents and he says, look, I've had a cough now for about 8 weeks, a couple of months. Yellow sputum, not much. No fevers, no contacts haven't been overseas, nothing very interesting. I used a nasal spray, it's still going. Again, clinical examination normal. And he was treated with empirical antibiotics and advised if he doesn't improve to have a chest x-ray. Another 6 weeks go by and he presents. And by now he's been coughing for about 3 months. And he describes it as dry. There's scant amounts of blood, and I'm hoping people are jotting down things. And I think, and this is absolutely about how we can dissect a case and think about reasoning and think about key things. And I'm hoping when you see blood, you're thinking red flags and the importance of those things. Not that that's comprehensively documented, but that's one of the things. No fevers, thinking about other differentials, GORD or, asthma, that sort of thing. His chest is clear and, again, an encouragement to get a chest x-ray and some bloods were done, including, I think, for some serologies. 3 weeks later, I make a call to this man and I have documented him in my handy notebook, which I'll again make reference to later in the session. And he says, look, to be honest, I haven't had my chest x-ray. I haven't really got around to it, but he's still coughing. He was and I'm conscious now I'm going to use a term that wasn't meant to be ironic, but it is. He was very phlegmatic. He was pretty chilled, this guy. And despite the fact he'd been coughing for 3 months, he certainly didn't. And I think I tried to instill a little bit of, urgency about this. He goes off and he gets his chest x-ray. And again, this isn't his film. It comes from the internet. Now, and for those of you who are thinking, gosh, I don't look at so many x-rays. I tend to read the report. The only thing that you could work out is that this film was actually the right way round. It intrigues me that they seem to have medical advisors. This is actually Ozark from a few years ago now, and they still persist in putting up chest x-rays the wrong way around. So if the only thing you had picked up there was that was orientated correctly and it doesn't look great at the right base, then you're on the money. Because his report said lower zone patchy consolidation on the right, recommend a follow-up film in 4 to 6 weeks, as is pretty routine, and if the changes persist, may be worth considering cross-sectional imaging, which is a very commonly seen thing on reports. So at that point, we put him on, took some sputum, put him on Augmentin and said, let's see what's happening in a couple of weeks. 3 weeks later, he does have a follow-up film and there's radiological improvement. Recommendation to confirm that it all gets better, and again, probably no surprises there. 4 weeks later, he comes back and you can see the number of encounters he really racking up. And he says, look, I think it was improving, but it's still going. He's given more antibiotics, and again, you might think, is that good or bad practice? And told again very explicitly to get a repeat chest x-ray. 2 weeks later, he comes back, he's still coughing, but he hasn't had an x-ray. So he's essentially sort of frog marched down to the radiology rooms, which is sort of down the street, and held up in front of the imaging box. And he has ongoing changes at the right base, including, and I remember my heart sinking about this point, blunting of the costophrenic angle with an effusion possible, and really starting to think, oh my goodness, this isn't looking good. So the next day, and I work in the city and we can have pretty good access to radiology, he has a CT scan, and you can read that yourself, but this was a pretty devastating result where there's possibly, or concerning for an endobronchial lesion and mild mediastinal lymphadenopathy on the right. So it was about around this time in my other role as an educator, I came across this paper, and it was an MJA paper about how often patients presented with various cancer diagnoses in Australia, in Victoria in this case, to kind of give us some sense that in fact it's not usual that a patient with a thyroid cancer or a pancreatic cancer or indeed a vulval cancer will be picked up on sort of the first presentation. This is a useful and interesting paper to read. And again, everything I'm referring you to here, I would also similarly recommend maybe your registrars to read. But there's no mention of lung cancer here, and there's certainly no mention of, multiple visits. So I referred this man to the Rapid Access Lung Cancer Clinic, which we have, again, accessible here. So we sent him off there, and of course he was seen quickly, and he had his bronchoscopy arranged. And I was actually given a phone call by the respiratory physician who did the bronchoscopy and said, yeah, I've just seen your patient, and I'd just want to give you a sense of what's going on. He has a peanut lodged in his airway. I'm still not quite sure whether the patient or myself was more relieved. He was still actually reasonably chilled, this fella. And he went, oh, yeah, vaguely remember eating a peanut and inhaling it. There you go. So this is a case of a delayed diagnosis. It is a case of a diagnostic error, as we'll talk about, but it had a reasonably good outcome in that he didn't have a nasty malignancy. What he did actually end up with, out of clinical interest, was a bronchiectasis, and that lung is bronchiectatic, maybe not surprisingly, and he has a chronic cough, but I guess that's better than having had a thoracotomy. So that is, I guess, a case, and in many respects an invitation for you to think about some of these really illustrative cases that we've all come across in general practice. Jot them down and maybe use them in teaching. They're the sorts of things we share with our colleagues at times, but maybe not deliberately used with registrars in practice. And maybe similar to what I've asked you to do, just sort of say, look, pick that apart clinically, but also those factors that might have contributed to a delayed diagnosis. And let's talk about those things. So what is diagnostic error? Obviously, like what's clinical reasoning or what's uncertainty, there's going to be multiple definitions. But one I think that's useful is this, it's twofold. And I think this is really useful for registrars. It's not just to make the diagnosis, it's to communicate that explanation to the patient. And of course, communication not only entails being able to impart that information to the patient across the desk, I was going to say, not many of us practice across the desk anymore, but also all the things that lead to it being able to be communicated, like system problems, which we'll talk about in a sec. This is AVANT data. It could be any MDO, because I think they're all pretty similar. And it's interesting that about more than a third of diagnostic error for ourselves and for physicians claims about a third are related to diagnostic error. It's much lower in a surgical cohort. I guess it's much more around procedural and management error. And I remember reading something about wrong side surgery that I used to quote and think, well, is that ever accurate? But I thought I'd look it up before this webinar, and I came across a paper that was published about 2 or 3 years ago, but it was a 20-year data set from 1990 to 2010. So things have probably improved over that time. But they talked about 2,500 wrong procedures, 2,500 wrong site surgeries, and 27 wrong patients. So despite the advent of checklists and all the checks and balances, stuff still happens in the healthcare system, as you probably wouldn't be surprised by. Not only is it popular TV series directors, but ABC journalists who can't quite get the orientation of imaging the right way around. It always makes me laugh. If you did manage to write down a few things or just reflect on our 64-year-old who ended up with a lodged peanut, what factors did you observe in that case that contributed to error in terms of thinking about teasing this stuff out with registrars? I tried to actually document what you saw from the notes fairly verbatim. We saw multiple doctors, and this is a really big plug. Obviously, new doctors can be fresh eyes, but it can really disrupt the continuity. He did have an underlying respiratory diagnosis. Not that I'm going to hide behind the patient factors, but he really wasn't too worried, and he was quite sort of lax about following things up. A red herring, and that's one of our cognitive biases, that we attribute things to something that maybe wasn't so significant. Not enough use of the recall system, follow-up results, I do some work with Medcast, and some of you may have heard me present hot topics recently, but one of the really, really big topics around at the moment is non-smoking lung cancer. And this has, as with bowel cancer, both these, the rates of these in younger patients has increased significantly. So absolutely another really interesting bias. Does he have cancer? No, he can't. He's not a smoker. Clearly oversimplification. Did I ever ask him if he thinks he inhaled something? No, I didn't. And that might have been actually really useful. But they are absolutely the sorts of things that I think you, and would encourage you to generate from a registrar. It may be hypothetical. Look, I can imagine these things are going to contribute to error. Or it might be, that's what happened to me when I misdiagnosed somebody recently. And so having a kind of list is useful. And you'll have access to all this and you can use. And so the literature practically talks about the factors that are related to diagnostic error as 4. There's doctor factors, there's patient factors, there's disease factors or presentation factors, and there's system factors. Yeah, I won't go through these in depth because many of these are, relatively apparent, but I think from a teaching perspective, there's some good ones to highlight. So let's start with the top left, presentation factors. Clearly, we operate in an environment of undifferentiated illness, earlier presentations. It's hard and it's tricky, and we need to encourage registrars to think about the way they practice with that sort of scope of uncertainty. But as somebody said, generating a broad differential is so important. Atypical presentations of common disease I think a really, really powerful teaching tool. So whenever you think, gosh, that was a curly one, that patient ended up having ischemic heart disease, but gee, they didn't present like it, write it down, use it in your teaching. They are such powerful tools, I think, because the low prevalence conditions, the rare things, they're going to be hard. I mean, unless you're sort of reading the texts and studying for your exams, we're not going to be across a lot of this stuff. What I am endeavouring to do is to respond to the registrar that says to us, so what are the common conditions? I could ask you guys, what are the common conditions that are prone to diagnostic error? And, these do have an overrepresentation in the MDO data sets. Shingles. I remember seeing a patient, I saw him on a Saturday morning, so I've got this terrible chest pain, I'm feeling really sweaty, I feel so unwell. I thought, oh man, this guy's having an infarct, and he took his shirt off and he had shingles. Pancreatic cancer, TB, ovarian cancer, great. So these, again, really useful to say, in my experience as a GP, these are things that get missed. But what's really powerful is that no one thing represents a particularly high proportion. So what we're talking about is generic. It's across the board. It's useful strategies for all these conditions. And we can't be across all the low prevalence stuff, but atypical presentations of common diseases are useful. Patient stuff, poor historian, I put that in inverted commas because, there's lots of evidence to say no patients are poor historians. It's just that we're poor history takers. I know that's probably provocative and you might wish to challenge me, and that's okay. But yeah, the patient factors, hard to get the information, the story changes, they're complex and sick and a whole bunch of stuff going on. They don't get their chest x-ray when they're asked to. And patient self-labelling is this notion of attributing symptoms. They say, I think, my headache's from stress. I've got this terrible stress headache, and we can, again, have a cognitive bias to listen to that. There's a whole lot of doctor factors, lack of knowledge, and that's our registrar's real concern. I don't know anything. How am I not going to miss stuff? Hungry, angry, late and tired is what HALT stands for. Communication barriers, which are very commonly identified in the MDO claims. We'll talk about biases in a second. Of course, time pressure. And yes, there's lots of system factors as well, about bookings and about systems and about recall and reminder and IT and the rest of it. Cross-cultural and language barriers, absolutely. So there's lots of things here that... So, again, I think a really useful list, most of us know this, registrars will be able to generate this, but it just gets them thinking about, well, which of these things, am I ending up hungry, angry, late and tired at the end of the day because I'm running late and, something needs to change? Am I time pressured? Are there some cognitive biases, which we'll talk about? Am I not using the recall systems appropriately? And of course, it's never one thing. And this Swiss cheese model of error is a really, really useful one to say there's often multiple factors that lead to the error. And my story that I like to share is that, and you can literally tick your way through this story of all the kind of factors that make it probable or more likely that there's going to be an error occurring on the day. It was a Saturday morning. Already different sort of context, different way of practicing. So it's just me and the receptionist. There's no practice nurse. I was in a different room because we used the room at the front of the practice. So my things weren't quite there. I saw a 42-year-old woman who presented with central lower abdominal pain, who had presented to the after hours service, I think a day and a half previously, with the same low-grade, vague central abdominal pain, had been diagnosed with a urinary tract infection, had had a pregnancy test at the time, and again, you can see where the story's going, and whose period occurred 2 weeks previously, and who, I'm exaggerating now, but whose husband had had a vasectomy. There were lots of things suggesting this woman wasn't pregnant and that she didn't have an ectopic. But I remember saying, if I turn around and in my trolley there's a pregnancy test, I will ask her to do a pregnancy test. But she had one a day and a half ago. There's so much here to suggest she's not pregnant. It sounds like a UTI. And she had some white cells in her urine, I think. Anyway, fortunately, the pregnancy test was there. I tell you, she was positive. She had an ectopic. And to me, I always think of this image, and I think of that last bit of cheese. There wasn't a hole, and that was me bothering to look for a pregnancy test kit. And that could have been a very different story. And again, those stories I think are really powerful reasons, but not excuses. So this image comes from a resource that I'll point you to at the end from the Clinical Excellence Commission here in New South Wales. And it refers to this sort of integral relationship between clinical reasoning and diagnostic error, and how our medical knowledge, and we make our clinical assessment, take a history, examine the patient, distill the letters from the specialist and the investigation results and the last discharge summary, and then we reason, and there in the middle is this interface of what happens and how likely we are to make error. But what's really useful is if you have a look, and this is what is, I think, so useful to talk to registrars about, that the lack of knowledge per se individually is actually a tiny fraction of why we make error. It's so much more about the way we reason. Now, having said that, clearly you need some knowledge to be able to reason effectively, but I think this is of some reassurance to registrars. If you can reason well, you're less likely to make error, and of course as you become more experienced and your knowledge accumulates, you reduce that further. Faulted data gathering, and this is pretty straightforward, pretty practical. Take a good history and examine the patient. This is not a talk on clinical reasoning. I love clinical reasoning. I think it's, when people say to me as an educator, if somebody said, supervisor new to the gig came up and said, what do I teach my registrars? I'd say there's two things to teach them. One is how to consult, to run a safe, effective consultation. And that's such a rich, wonderfully interesting area. And the second one, as part of it, is how to reason. Everything else will come. And so this isn't a talk on reasoning because there's lots and lots we can talk about, and I can very happy to run one on reasoning later in the year. I did one a couple of years ago. But one of the little bits of reasoning that relates very strongly, as you just saw in that previous slide, to diagnostic error is cognitive biases. And these are these flawed systems of thinking. They're kind of an approach we take that overrules, I guess, a more rational interrogative method and leads us to bias and potentially leads us to error. And here, this illustrates two of them. One is sort of confirmation bias, that, I'll just continue to ask the questions that to support my diagnosis here. And the other one is overconfidence bias, that is very much, I think I know what I'm doing, and I guess not questioning oneself. So these are two of multiple, maybe, again, how long is a piece of string where it overlaps, but up to maybe 30, 40, 50 cognitive biases. And these, if you're not talking to your registrars about, fabulous, rich area to explore and encourage you to do. And this is really, I guess, a combination of biases. It's just one tiny little example because I think it's interesting and fun that you're very, very welcome to pinch. to illustrate self-labelling, as we were talking about, I think I have another UTI, but also these sort of affective biases, and probably others, of your relationship or maybe even first impressions of the patient. This is Zoe, she's 28, she thinks she's got another UTI, and she presents with dysuria and pelvic pain. And, you know, that's a lovely STEM, KFP type thing, or AKT question. Registrar generates the differential, you know, a great exam question. But let's represent Zoe, who's 28, and she thinks she's got another UTI, and she's presenting with exactly the same symptoms. And this is about bias, and this is about influence, and this is about how maybe we change our practice on even just one simple parameter, and that's what how the patient looks. Here's Zoe again. She's 28. She thinks she's got another UTI, and she's got exactly the same symptoms. Does this change the way we think? Does this change the way we data gather? Our knowledge is the same, but our reasoning and synthesis may be different. And here's Zoe, the last Zoe, who's still 28, and she still thinks she's got a UTI. Maybe of all of them, the most challenging, with exactly the same symptoms. So that's a nice little exercise, and there's lots of those. So when I talk about error, and would encourage you, when you talk about error, please weigh heavily into the clinical reasoning stuff and try to interrogate the registrar's reasoning processes. The availability heuristic, that's again one of the biases, very much, you know, what's familiar, and that can be useful. It can also be quite distracting, and I use the example of the missed pulmonary embolus that, you know, you took a while to diagnose, and eventually these vague symptoms turned out to be a PE, and you do a CTPA on everyone with a sort of sniff of breathlessness for the next few presentations, because what's available to you is, my God, I missed a PE, and, you know, you're really thinking about it. You've got a registrar, you've got a student, and they say, you know, you're an experienced GP, this is a minefield. You know, patients are coming in, general practice, I know, is characterised by undifferentiated presentations, they're early in their disease course. You know, often there's not much to find on examination. We do tests and they don't even match what we imagine might be happening. The specialist gives us another opinion, different to what we think. The patient's sort of telling us what they think's going on. How do you manage it? How do you manage this? This is, I guess, around uncertainty, but what sort of strategies do you use to actually minimise the likelihood of error? How do you respond to that registrar? Prompt, which is Murtaugh's model, which I'll talk about. And again, I imagine most of what I'm about to go through is not something you're going to go, oh, I hadn't heard of that. I'm just wishing to collate it a bit, to bring it to the forefront a bit, to encourage you to maybe tease your way through some of these things with your registrars, to take a lunch break. And, you know, but I'm already behind and I've got notes to write. You're going to be far more effective and safer, and you're going to make less mistakes if you do that. So that's a good strategy. You know, good history and examination is an absolute baseline. What other things would you say? Because these registrars, remember, these guys are quaking often. This is fearful stuff. They're terrified of missing something. How do we do it? It's common nature. It's common practice for us. Start from the beginning and ask a colleague. I think that notion of taking the history from the beginning, I think, is really powerful. And that's for me, a point I make with registrars. Sure, read the old notes. That's incredibly important. But ask the patient to start from the beginning. And if you get 2 or 3 kind of consultations in, like I did with my man, perhaps say, look, I know what's been happening. You've been telling me, I've written it all down, but pretend I've never met you before. Give me it from the beginning. That's a really useful way of doing it. And registrars, I think, are not very good at making definite future review appointments. They just kind of come back but you know, open the appointment book and say, I've got a slot here. That's when I want you to book in. I'll put you in myself or go out to the front desk. Come early with the problem. So absolutely seek help. Don't hold back and don't be embarrassed. And, you know, particularly if something might have gone a little bit sideways, it's likely to go more sideways. So come early. Come back for review, one other doctor. A lot of registrars do spend a lot of time looking for clues. And that's another prompt to talk a bit about AI. Never send home a patient or keep you awake at 3 a.m. Yeah, that is so valuable and so safety netting. Isn't that wonderful? This was the man with the shingles. If I hadn't taken his shirt off, I would have got the ambulance in. And if this doctor hadn't kind of taken this guy's shirt off and looked around the back, he wouldn't have seen that it isn't kidney stones. He's got a rhino horn. And so this notion of history, and the point I think is about starting again. It's not about exhaustive histories all the time. I think that isn't the message, because, general practice has to be focused and it has to be efficient. But where there's a sense of things not quite being resolved, absolutely. And of course, an appropriate examination. This diagnostic pause, but for registrars, this is foreign and confronting and potentially credibility damaging. And my goodness, are you telling me I can actually stop and think in the consultation? But maybe your registrars have no clue this is a part of their armamentarium in minimising error. And this is, as you know, carving 10 or 15 or 20 seconds or even a couple of minutes out of the consultation to actually just go, what on earth is going on here? What can't I afford to miss? What's the most appropriate way forward here? Maybe even get some help, look up stuff. And registrars need and should be encouraged to incorporate this into their consulting, because they just will, not only will they not do it, they'll see it as shameful or not part of what you do. Using your formal words here to the patient, do you mind just sitting quietly? I'm just going to have a think about what's going on with you and maybe just make a note or two. Patients just respect that. That's fabulous. Oh, my doctor's actually thinking about, take a few notes, sit, look away, and then come back. Or, there's the urine jar for the unnecessary urine test to buy even a bit more time. And the power of ICE, ideas, concerns, expectations. And again, we do this. This is what we do as experienced, expert clinicians. But registrars probably need to be reminded. They will have come across this in our sessions and medical school. But to be able to say, something's not right here. I'm just not working this out. The patient's struggling with being able to let me know what's going on. I'm struggling to work it out. I'm going to pull out my ICE questions. What do you think's going on? What are you especially concerned about today? What were you hoping to get out of the visit? And those 3 questions or versions of those can absolutely open things up and again, potentially avoid error. And so for us, it's like, yeah, well, of course I'd be asking those things. For a registrar, it's potentially not something they'd consider. I alluded to not elaborating on rational testing because it is a big topic and one that probably needs sufficient input, and one I will do because I'm very keen to do it. And again, it's been a real passion of mine over the years about how to find this sweet spot between undertesting and potentially diagnostic error and missing stuff, which registrars and we all fear, and over-testing. Let's chuck everything at the patient and we'll make sure we don't miss anything, but causing harm. As I'll talk about when I run this session, genuinely causing harm. Patients get hurt by too many tests. So it isn't just, just not expensive and it's not just a headache to kind of wade through a whole bunch of results. It causes harm. So how do registrars get to this point? And again, I'll tease that out at a later point because there's lots of strategies around this and there's lots of evidence and good work around it. And for many registrars, they will just fall into the over-testing pattern by virtue of their hospital experience and by virtue of that they don't want to miss stuff, so they just test a lot. And they just nudge their way back towards a sweet spot with experience. But we do usually, that's most registrars, but we certainly aim to encourage them not to do too much over-testing early on. I tell the patient they can watch my cogs turning. What a wonderful, wonderful set of words. And I think one of the most powerful things we can do with registrars, this is a bit off topic, isn't just role-playing, isn't just saying, you take my bit of history or you explain it to me, but it's saying these are the words I like to use when I'm with my patients, and try them out, see how they work for you, and giving them some of those useful phrases. This is a great paper. It is in the BMJ, I think not freely accessible, but your library will be able to get it for you. And I would read this. It's about 3 pages long. It's written by GPs, and you can see at least one name there as familiar to you, probably Paul Glasziou. And it is so familiar. It's like sort of bedtime reading. It's about how we as GPs diagnose, we go through this diagnostic process. And something I'd strongly encourage you to have a look at and just give it to the registrar and say, read this, because it talks about a whole range, and again, I won't go through this, but a whole range of strategies around how we initiate a diagnosis with some of those sort of triggers, how we refine the diagnosis with things like prompt and a range of things, and then how we might define the diagnosis with tests or a test of treatment and those sorts of things. Prompt, obviously the Australian model, internationally regarded as a safe diagnostic approach, as it's called, and one I know most of our registrars, well, all of our registrars are familiar with, and I think many of them use. But as educators, which is my experience much more so than supervisor role, the notion of a broad differential and then refining that is so much of what we do, and again, an encouragement to do that. So think broadly, refine the diagnosis by using things like red flags, what's often missed, what sort of masquerades, and of course this is nice in practice, what's the patient telling me? So there he is, Uncle John Murtagh, who is the grandfather of our discipline and a very impressive man. So I'm kind of going through this list now, and it's hopefully in some, I was going to say chronological or temporal order, through the kind of the consultation history, examination, the diagnostic process, investigations, sort of working through. And then, of course, there's biases. Now, this table comes from the clinical reasoning guide that GPSA have. Again, I don't see any distinction between minimising diagnostic error and good clinical reasoning, so it's all the same thing. So have a read of that. There's a section on cognitive biases. Now, really interesting, the literature on this, there's a lot around so-called cognitive forcing and how in the cut and thrust of busy general practice, when we are saying, I always like to say, I'm starting my talk off on diagnostic error with a case of a man who presents with a cough. And of course, this guy is not going to have asthma or a post-viral cough. He's going to have something sinister. But in real life, every single one of our patients potentially could have something that's going to turn into a diagnostic error. So how do we minimise biases? And there's these strategies that have been written up and certainly tested. My reading is that the overall evidence is that it's a really, really hard thing to know that you're doing and to actually force yourself not doing it. Now, having said that, I think registrars and ourselves knowing maybe how we practice, maybe how we fall into traps in our thinking, certainly some of them I think are very able to be influenced by teaching and by reflection, things like patient self-label, things like diagnostic momentum, where they've got this diagnosis and it sticks to them, and I'm not going to question that. No, maybe you should question that if things aren't adding up. So there's a few of these I think that are very hard to recognise when we're doing, but others I think that are much more teachable. So have a look at that. And one of those things in the clinical reasoning guide is around metacognition. And I love talking about reasoning, I love talking about metacognition, and this is just a fabulous, so I'm sort of really straying into reasoning here, but this is a fabulous image that comes from this paper around how we reason effectively. And again, I won't go into it in detail, except that there at the bottom is knowledge acquisition. So you kind of have to have a decent knowledge to make a good diagnosis. Illness scripts and processing, and that's where the biases come in. But this metacognition, which is this sense of thinking about our thinking, as in they're aware of themselves thinking. They're almost sort of seeing themselves with the patient. They can see their own cogs turning and thinking, I don't want to make a mistake, and I'm tired, but I've got to attend to this. And if people said no, that's fine. I think it's not some failing or flaw, but it is sometimes is actually the point that it doesn't always happen. Sometimes we just are not metacognitive. But if we can somehow encourage this in our registrars, and that's, you do it and teach it regularly. I want to know how you teach it, because I think this is such a powerful skill. How do you teach this? But I think talking about it, even if you're thinking, I don't know how to teach this, but I can at least describe where I get to, a registrar is going to recognise it when they're there. You're not meant to look at these guidelines, but just to say we do have guidelines. Guidelines can be, of course, extraordinarily useful in minimising error. Why don't we access guidelines? Are we too proud? We don't want to undermine credibility by looking stuff up in front of the patient. We don't know they exist. We don't know the login. All sorts of systems issues might contribute to this. And, they might just not be relevant. But where they exist, registrars should access them. And of course, health pathways is getting up there, and ETG, of course. But, health pathways is an incredibly powerful set of guidelines. Somebody mentioned help seeking, so calling for help. And this isn't just from you guys, supervisors, but it's from the lab or from the friendly specialist down the road to say, I've got these really strange blood results, or the patient's presented in this way. Do you think I need to do something different? But my question is, what links Sully, this isn't Sully, this is Tom Hanks pretending to be Sully, who's the airline pilot who landed the plane in the middle of the Hudson River, which maybe isn't a great example, isn't it? You might describe that as an error, but I think he wasn't at fault. And Homer Simpson, what describes these two men's occupations? What do they use as part of their occupation to minimise error in their job? And something that we don't do very much as doctors, and we could probably do a whole lot more. Checklist, that's exactly right. And why don't we use checklists? It's actually a fascinating question. Why don't we pull out the dyspnea checklist for the patient who's got breathlessness to work our way through and say, my goodness, I didn't even think of an embolism. Let's think a bit more about this. And that is rhetorical, and there's going to be lots of reasons to support it and otherwise. But yeah, thinking about checklists, they might be a really useful addition. Gut feelings. I feel bad about this patient. I'm worried about this patient. Everything adds up, but gosh, I feel uneasy about this patient. That is a powerful, well-described tool in the literature to help us minimise error. And again, something I would encourage you to say to registrars, you're going to have two feelings. One is a sense of reassurance. Yeah, it's kind of going along all right. I'm feeling like this patient's progressing, improving, whatever. Or, oh, this isn't good. And if you have that, do something. Do a test or speak to someone or look something up or get them back or whatever. It's a really, really interesting and rich literature on gut feelings. Communication of uncertainty, we've talked quite a lot about and involving the patient in decision making. We've talked a bit about recall and reminder systems and utility. And I just want to make a plug for the simple notebook to say, like my man at the beginning, and maybe some of you thought, you called that guy? Like he didn't have his chest x-ray and you gave him a ring? How did that happen? It's because I wrote him in my notebook. And that sounds a bit old-fashioned, and maybe that's because I am, but some system, and this isn't every single patient, clearly, but it's the ones you think, I can't let this guy disappear. I really need to know if he's got his x-ray done or he's seen the specialist or he gets his bloods checked because, I'm worried about this patient and I don't want there to be an error from a systems issue. We touched on safety netting. Again, there's a really rich literature on this, and I think registrars are really, I have to be honest, I think they're actually really poor at it. They don't feel comfortable getting people back because they're not used to doing it, and they don't know the time frames for getting people back, and they don't have the same sort of confidence about when and how, and they safety net poorly on the whole, particularly those early on. And to go through safety net isn't just come back if you're not well or if you haven't improved. It's a time course, the natural history, where to come, what if it's after hours, all those things again we've talked about. And lastly is the whole notion of AI. And interestingly, the college have just put out a recommendation about the use of AI scribes in registrars, which I think is public. Basically, GPT-1 shouldn't be using AI scribes. Now, you might think that's a bit retrograde, and why should they just move from GPT-1 to GPT-2 and start using? I've just started using Heidi. I think it's great in many respects. I think it does absolutely have the capacity to undermine my clinical reasoning. That might be a bold statement. Many of you might think that's kind of an exaggeration, but I worry about the way it will influence my thinking. I love the way it captures bits of information that I probably wouldn't write down because I don't type quickly. But I do think there's a risk there around how it might impact on a registrar's reasoning. This is just simple recording systems. This isn't where there's a diagnostic model attached to it. It's just the way it captures information. We all know what it's like to work our way through notes, to write, to think, to summarize, to synthesize, and then think, yep, that's what we'll do. And this, I'm worried, will undermine that. That's my summary slide. You can have access to that. We've talked about all of these. And I'm pretty much done, but I came across this paper, Missed Opportunities for Diagnosis, Lessons Learned Through Diagnostic Errors in Primary Care. And I thought it was really interesting that there were 4 big ticket items. Here they are. So how pattern recognition can be a source of diagnostic error and how we can use atypical presentations in our teaching, how we can use red flags and Murtaugh's model to rule things out, how we can use gut feelings, and how we can use management of uncertainty to reason better and to reduce the likelihood of error. Again, all the BJGP papers, which this is one, are freely available, and it's a really nice paper to have a read. I love this last line here. For you guys as supervisors, for your registrars, finding more ways to learn from error from your peers and yourselves could be invaluable. So really be plugged to incorporate diagnostic error into your teaching, using those words regularly about error, about biases, about factors that are contributing. We have a teaching plan. We have a clinical reasoning guide I've referred to. I imagine most of you know about I am reasoning. I have a registrar who, he failed his KFP. And then I said, are you using I am reasoning? He said, no. What is it? And I told him, and he started listening to the podcast. He said, I fundamentally changed the way he practiced. He now practices and thinks like a GP, these are his words, and he passed his KFP and his writtens and his clinicals, which was wonderful. There's a great series in the BMJ called Easily Missed, and the Society to Improve Diagnosis in Medicine has a kind of clinical reasoning toolkit, which you might be interested in. And I won't go through this Take Two method, but this is a nice resource too through the Clinical Excellence Commission. I think New South Wales, but it's freely available. Have a seat, Kermit. What I'm about to tell you might come as a big shock. That's my last cartoon, which isn't actually really very relevant to diagnostic error. I just think it's funny. And thank you to you guys. I hope that was of some value. I really hope that was a good kind of overview. Thank you all very much. Wonderful, and look forward to seeing you at an upcoming webinar, and we'll talk soon. All the best. Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.